objectives for the day are to learn how to code correctly for different levels of patient visits. We'll talk about some places where you might make mistakes in allergy-specific codes, and also, since we're using ICD-10, we'll talk a little bit about that toward the end of the talk. So everybody wants to see patients and do what we need to, and coding sometimes becomes kind of a frustration and aggravation as an added-on part of our patient visits. But we have to code because payers want this information. They want to make sure that we're doing what they're paying us for, that we're telling them where we're doing things. And more recently, one of the big concerns is that what we code for is actually medically necessary. With the advent of electronic health records, there has been a concern that people are coding for both things that they're doing and also the extent of which they're doing them, which may not be medically necessary, and we'll talk about that a little bit further. So the first important resource for you all is the CPT manual, and this is the CPT comes out every year. It's current procedural terminology. It's published yearly by the AMA, and it really has most of the information that you need to know to code correctly. And I'll just go over a little bit of the table of contents with you here, which shows you the E&M service guidelines. So evaluation of medicine and management basically refers to any visit that you might have with a patient. And as you know from training, the critical aspects of that visit include taking a chief complaint, and every visit should have a chief complaint, knowing what the history of the present illness is, and understanding a review of systems. Now, all of us usually do these things. The importance in terms of getting paid is to actually document these things. So in addition to those areas, you have to include a past history, social history, and a family history. And those are the main elements that we think about when we see a patient and when we're trying to decide how do we code for this visit that I've had with this patient. The extent of that information, that is the amount of history, physical, and another component called medical decision-making, will determine the level of the E&M services. And as you can see, since this is in the table of contents, all this information is within the pages of the CPT book. So you can read about it. I'll show you a little chart in just a minute that kind of summarizes it to put it in perspective. But the more information that you need to gather in the history, the more extensive the physical exam, and the more difficult the medical decision-making, the higher you can bill for that visit, for that either new patient visit or follow-up visit with that particular patient. Now, it's complicated, and Medicare has gone to some effort to try and make it easier for us to do, and they've published some fairly simple guidelines for us. And to get this evaluation of management services from Medicare Learning Network, you can just Google Medicare Learning Network evaluation, and you'll come up with this August of last year publication that goes through some of the fine points of how you document and proceed to get your payments. Some of these that I'll point out to you are kind of interesting. The documentation guidelines that Medicare uses are from 1995 and 1997. There have been some attempts to revise them and update them, but they haven't been. And so these are the two guidelines that are being used. And it's actually the earlier guideline, the 1995 guideline, that's most commonly used, because it allows you a little more latitude in how you define your physical exam. So you actually can define the physical exam in the 1995 guidelines. If it's a complete allergy evaluation, then it's complete in your eyes, and they don't require you to have specific points that are covered in the physical exam. Now, at least one insurance company does not allow the 1995 guidelines, but most of them will tell their auditors that you will use the guideline that is more favorable to the provider. So the auditors are supposed to be using either the 95 or the 97 guidelines if they fit into your history, physical, and so forth, that will give you the better payment. And that's something, that if you can document, then you may have reason to appeal a denial on that basis. Let me go through a couple of the documentation guidelines that they talk about that are important to us as allergists. And I've tried to underline those on this. The DG is just documentation guidelines, and these are from that pamphlet that I showed you earlier that's put out by Medicare. And it says a review of systems, past family social history obtained on an earlier encounter does not need to be re-recorded if there is evidence that the physician reviewed enough. So this is really important with electronic health records. Some people will go back to a previous visit, and if you just cut and paste this information to a new visit without any comments, then Medicare can come back and say, well, that's just a cloned medical record. You really didn't review that previous review of systems that you mentioned, and you didn't take a new past family social history. So what you have to do is you have to describe any changes or say that there's been no change, and then you also have to put the date and the location of the earlier information that you're using to show that you went back in the record and reviewed it with the patient. So there has to be some evidence that you actually did these things rather than that you just cut and pasted it, put it in there, and therefore you've increased your reimbursement. The other thing that that is important here is that the review of systems, the past family social history, may be recorded by ancillary staff. So you can have the patient actually fill out a form. You can have somebody else in the office fill out this information for you, and you can incorporate it into your record. But what you cannot do, according to this, is you cannot have somebody else fill out the present illness. So it's the duty of the provider to actually not only take the history of the present illness, but also to document that. So you have some requirements and you have some flexibility, but you need to follow the guidelines to make sure that they understand that you actually did all these things. So let's talk a little bit about coding for office visits. When you code for an office visit, you pick a level of service that represents what you did. And so there are 5 levels of service for new patient visits, for consults, for office visits. And I'm just going to go through those quickly with you because, as I said, the information is in the CPT book, and it really requires just a little bit of reading and remembering and using before you kind of get it down. But to give you an example, this is a level 1 visit for a follow-up patient. The code is 99211, and it's really what we call a nursing visit. So it does not require the presence of a physician. It's one of the few codes in the book that does not, and it typically is 5 minutes, and it might be something like a patient coming back in for a blood pressure check, or a patient calls and says, well, they had a large local reaction after their shot and they're worried about it, and you have one of the nurses see them, and they come in and the nurse records the size of the reaction and talks to the patient about their symptoms, but you never actually see the patient. Another place this is used is when a patient will come in and say to a nurse before they get their allergy shot, well, my medicine's changed since my last shot, and now I'm on a beta blocker or something. And the nurse says, well, wait a minute, I need to go talk to the doctor, find out if we need to change anything or do anything. So that there's no face-to-face encounter with the provider, but the nurse gets some history and then talks to the provider about the patient, and then goes back and gives an allergy shot, and may also record a nursing visit at the same time. So you might get this code used with an allergy shot code. One of the things you always have to remember when you bill a patient for something is insurance works in different ways, and some insurance requires a copay for an office visit but doesn't require a copay for an allergy shot. So the patient might be billed a copay if you do that, whereas if they just came in and got their allergy shot, they would not be billed a copay. So there's pluses and minuses about using this code. It will increase your reimbursement, but it also will potentially cost a patient a little bit more. A more common code that we use every day is a level 3 code, which is 99213, and see if I can get that to advance. For some reason that's not advancing. I'm not sure if you can advance it from there.
But Charlie, can you take your mouse and click on the screen and then try to advance it?
Okay. That did it. Thank you. Whoops. Did it too much. Okay. So there we go. So there's the 99213. And there are a couple of points that I want to remind you of. In a follow-up visit, you need at least 2 of the 3 key components. The 3 key components, as I mentioned, are history, physical examination, and medical decision-making. So you can see on this, and you can read in more detail in the CPT manual, that this particular code needs an expanded problem-focused history, and that's gobbledygook unless you look at the manual and figure out what that actually pertains to, and also an expanded problem-focused examination, and medical decision-making of low complexity. So I'll go over that with you in just a second on a chart. But the other thing about this is that it gives you a time down here. It says physicians typically spend 15 minutes face-to-face with a patient and or a family. And that becomes important as we look at other ways of billing and other bills that we can add on to this code when we're seeing a patient, that 15-minute time interval. So here's the table. It's complicated because I tried to get a lot onto this one slide, but I've broken it down into components on the next couple of slides, and we'll go over those in more detail. So this is the history for various levels of an E&M visit. You can see here this is a level 1 E&M visit for a new patient or a consult, level 2, new patient consult, level 3, 4, and 5. And when you're doing the history of the present illness, you can see for a level 1 and a level 2, you only need one component of these various factors that deal with the chief complaint. If you're going to bill a level 3, however, you need at least 4 or at least 3 chronic diseases, and similarly for a level 4, you need more levels. And for a level 5, you also need those factors. Now they differ in the review of systems. So if you don't do a review of systems, you can bill for a level 1, but you can't bill for a level 2 because you have to have a review of systems of at least one component to bill for level 2, excuse me, and at least 2 components for a level 3. Many times when we are working with a new patient, it really turns out to be a level 4 initial visit or a level 4 consult, but to actually bill for that, you have to record at least 10 of the components of the review of systems, and that's important because we'll see people that will send us their charts and say, you know, this was a level 4 visit, I billed them for a level 4, and you'll go back and you'll look, and the review of systems will be very meek and not well documented. And so the insurance company has said, well, you didn't really show us that you had the components to bill for a level 4, and they'll send it back to them and say, we're down coding it to a level 3, and this is often the problem, is this review of systems where the provider doesn't have enough components in the review of systems. And similarly, this is pretty easy. Past family and social history, you just need one, regardless of what level of service you're billing for. But think about the review of systems and make sure that you document well in your review of systems. Now you can see kind of the same thing for the physical exam. So we talked about expanded problem-focused physical exam, and you can see that that would be for a level 2. Level 3 would be detailed, and level 4 comprehensive. So this is where I was telling you before that the 95 guidelines are a little bit easier because you can determine what really is a comprehensive allergy physical exam. You don't have to check every one of these boxes and make sure that you've completed every one of these components to have a comprehensive physical exam. So the only way you're going to get to a level 4 or level 5 in some of your patients is going to be billing using the 95 guidelines, and that's why we like them. They really, I mean, we do all these things, but you don't have to touch every one of these various boxes. Okay, so in a nutshell, that's how you decide the level of service. That is how you determine how much, or I should say that the insurance company determines how much work you did by what you documented. And remember again that it has to be medically necessary. So you can't have every component in there on a person that comes to you, for instance, with a sore throat and say, well, I had to examine their heart and their lungs and their abdomen, and I had to do a complete history and physical exam based on the sore throat that they came to me with, because it's not medically necessary. But if somebody comes to you with a more complicated problem, if they have asthma or if they have chronic sinusitis and anaphylaxis, you can see where those diseases are chronic and require more information to be gathered and a more extensive physical examination. Okay, so as I said, the determination of the level of service with those will depend on the history, the physical, and the medical decision-making for a new patient, and if it's a follow-up visit, 2 of those 3 components. Well, think about the patients that you see that come in that they may have had allergy testing, and the visit was primarily for the allergy testing. They came in before, they told you that they had seasonal symptoms of rhinitis, and when you saw them the first time, you decided they would come back for skin testing, but they had been on antihistamine, so you wanted to give them time to get off their medicines and come back. You might do the skin testing and spend a lot of time talking about the results of the skin testing and what they needed to do based on that, but you wouldn't repeat necessarily the history, the physical examination, and so forth. So we have to have some means of dealing with that extensive review that we do with the patient, and that's billing based on time. So if you have a patient and they're coming in and you're billing based on time alone, then if you know the time that is spent face-to-face here in this first column, and a new patient visit, for instance, level 1 would be 10 minutes, and we looked before at that level 3 visit that I said was 15 minutes. This is where it comes into play. So if you spend 15 minutes with an office call, a follow-up visit, then that automatically is a level 3, as long as you do 2 things. As long as you document that greater than 50% of the face-to-face time was in counseling and coordination of care, and the total number of minutes that the patient was in the room. So you can say, the patient was sensitive to dust mites, and you had to go over dust controls with the patient, and it took you some time to explain everything to them and to explain to them how they could best do environmental controls, and it took you, said, 15 minutes to do all that, and over half of that time that you spent with the patient was in counseling coordination of care, then you could bill a level 3. Similarly, if you spent 25 or 30 minutes with the patient, that would automatically be a level 4 visit, and if you spent 40 minutes or more, you'd have a level 5. So oftentimes we spend a lot of time with our patients, and we educate them about a lot of things, but we don't take advantage of this opportunity to use the billing based on time, which will often give you a higher level of service. So I encourage you to look at that and think about that, and then remember to write in the chart total face-to-face time, and also that greater than 50% of the time was devoted to counseling and coordination of care. So if you get audited and they said, well, you didn't have the components of the history and physical, you can point to your note and say, I did this billing based on time, and here is the information that I recorded at the time of the visit that allowed me to do that.
Harry, this is Paul Dowling. I have a question for you.
Yes.
When you're doing that, even if you have a new patient that, let's say, just comes in for allergic rhinitis, the average patient in our clinic is usually here an hour and a half to 2 hours by the time you get everything done, okay? So you're going in and out of the room. I could see with basically any new patient we saw that that I could say the face-to-face time was 40 minutes and greater than 50% of that time was spent with counseling or coordination of a care plan by the time you do all the teaching and education and all the other stuff that you end up doing. So theoretically, then all these patients I'd be billing if I did that would be level 5, which I would think you'd be audited pretty quickly if everything was a level 5.
And you're absolutely right. So there are two answers to that. One is that if you're spending that much time and doing those things, you should bill a level 5. But the other aspect is you should have the documentation, and I think it would be true of your center that you're seeing the more difficult patients. You're not seeing the people that can come in and get a nose spray and go out. You're seeing patients that require more counseling, coordination of care, and understanding their disease, where it takes longer to explain this to them to manage their disease. So I think you have to have good documentation, but I think if that's what you're doing, then you should bill at that level. You don't want to down bill just so you don't get audited. You probably will get audited, but if you have the documentation, then you'll get paid also.
So do you think, for an academic center, because we do get kind of the worst of the worst, not the usual run-of-the-mill stuff usually, do you think we would be better off as a group if we all just billed based on time?
Well, I mean, as long as greater than 50% of the face-to-face time is actually counseling coordination of care, then the answer is yes, because I would assume in your situation that you have to spend more time either unteaching the wrong information to the patient and then getting them on the right track, or starting them out on the right track in a more difficult setting than I might in my clinic. So, I think, again, it wouldn't all be level 5s, but I think if you have a patient that requires that type of time and information, that you would bill for the level 5 because you're spending the time with them.
Do you know anybody that bills based just on time usually? I mean, are there groups out there that just made the decision just to do it on time?
Yes, and I've seen a lot of new patient medical records that I've reviewed that every one of their new patients is based on time. So it does happen, yes.
Yeah, I do a combined clinic with a GI doctor for eosinophilic esophagitis, and every patient for new follow-ups, whatever, we always base it on time because we just spend so much time counseling and explaining things to them.
Right. So I think that, as I said, I think this is underused. For a new patient, it would be 45 minutes or more because the new patient requirements are a little higher than the established patient codes. But yes, I think if you're spending 45 minutes or more with a patient, then you can bill based on, that would be a 99204. But if you're spending an hour with them, then it's a 99205. It's a level 5 visit. So, and the other thing I wanted to say about that, you mentioned going in and out of the room. You take the total face-to-face time in a 24-hour period. So if you are spending time with the patient and then you're called away or something else is going on with the patient, but then you come back in with the patient, it's the total time that you spend face-to-face with the patient over a 24-hour period that determines the time. And so it's not just 15 minutes. If you go in and out of the room 3 times and spend 15 minutes each time, it's 45 minutes because it's the sum of each of those 3 15-minute visits.
I think that's part of the issue is that when I do the EOE clinic, we go in and we usually spend the whole time and then we leave the room. And You may go back to give like a depart sheet or something, but for the most part, we spend all our time in one session, where when we see a new patient in allergy, we're doing PFT skin testing going in and out of the room. So a lot of times it's harder to keep track of all those individual periods of time that you're going in and out of the room, I guess.
Right, but it may be, I mean, just from a billing standpoint, it may be worth having a mechanism to do that, so you can add up all the face-to-face time at the end of the visit before they leave and decide, was my total face-to-face time greater, and should I, and because with a new patient you're probably spending most of your time with counseling coordination of care. So in that situation, then you can document the total time, total face-to-face time, and write in the note that greater than 50% was spent on those efforts, and get paid appropriately.
Thank you.
Okay. All right. The other area that kind of falls into the same category is that these prolonged service codes, and there are two kinds of codes that I want to talk to you about in prolonged service. One is with direct patient contact. So this is a prolonged service code where you're spending time with the patient, and it's an add-on code to the base code. So what that means is that you have to spend at least 30 minutes. Part of CPT says that if you have a code that is based on time, that you have to spend at least half of that base period to be able to base the code. So this code 99354 is based on an hour. So you have to spend at least half of that time, 30 minutes, before you can bill the code. And here you can see kind of how you bill it. So if you have 30 minutes or more, then you can bill the 99354 code, and then the code for additional 30 minutes is 99355 for each additional 30 minutes. And so you can look at how much time you spend, and you can figure out, well, how many units of 99354 can I bill, and then how many units of 99355 can I bill? And to make it a little clearer, here's a new patient, for instance. So if the new patient for a level 1 code is 10 minutes, then you have to spend at least 40 minutes, that's that extra 30 minutes, before you can bill the 99354. And then you have to spend that hour and half of the 30-minute interval for the 99355 before you can bill for a unit of 99355. So, and this is a situation where you might have seen this isn't as easy with a new patient, but you might have seen a asthmatic, and you saw him a week ago, and you worked with them, and they come back the next week after you saw them, and so it would be a follow-up visit, and you just get an interim history and physical. So it might be 99213. The typical time for that is 15 minutes, but they're having an asthma exacerbation, and so you have to deal with that. You have to nebulize them, or you have to give them epi, or you have to spend more time than just the minimal history and physical that would have taken to get you to a level of 99213. And if you end up spending, say, 45 minutes with that patient, the E&M for the initial history and physical might have been 15 minutes, or might have been enough to get you to a level 3, but that extra 30 minutes will allow you to bill this 99354 prolonged visit code. And so you'll get paid more if you do the prolonged visit code, and then if you spend even more time with the patient, total time during the day, you can bill for the prolonged visit code plus the add-on for another 30 minutes. So these are situations, they don't happen a lot, but they happen enough that you need to know about them. And what probably happens more is when you get a very complicated patient and you see them and they bring you a stack of records, and then you have to go through all those records and look at scans and review them, and the patient isn't always there with you. So there's a prolonged service code without direct patient contact that you can also use. So these are 99358 and 99359, which work the same way as the previous two codes, but they're without the patient in front of you. They have to be tied to an E&M visit, but the patient doesn't have to be in the room with you while you're using this time of yours to go over the patient's history and previous medical records and so forth. So very important codes to know about and to use appropriately when the situation calls for them. Now,
Gary,
yes.
I'm going to interrupt you again. I'm sorry. I was going to ask you about this, and you just kind of brought this up. The same scenario. On this coming Monday, I'm going to do EOE clinic with my GI colleague. These are all the patients we see in this visit, in this clinic are all new patients to myself and to my GI colleague that have been referred by other GI docs. I will this afternoon or this weekend go through 5 sets of records for these patients, which pages and pages, repeat endoscopies, 5 years of history, et cetera, or longer in some cases, and do that. I have never billed for any of that time that I've spent. I go in the room and then we confirm after I've made a list of all this stuff that I think is important. Then we go in the room and give a little scenario of what I gleaned from going through hours of their history, and then they correct things that need to be corrected. But for me, going through all these scopes and records and sent records from other doctors, et cetera, how do I bill for that?
Well, in that situation, you would actually have to pretend you're a lawyer and keep track of all the time you're spending and have a clock and a timer and say, okay, this is the amount of time that I spend with these records, and then in your note you would have the number of pages that you reviewed or the doctor's name who referred and the records that you reviewed, and said, I reviewed Dr. Smith's record consisting of 100 pages, including scans and scopes, and spent an hour doing that. And so that would be your documentation that would allow you to bill for these codes.
Now, since we don't do our own billing here anymore, it's done by somebody who looks at our charts, when I do my dictation on Monday for one of these new patients, and I always put the time spent with the patient for that visit, can I put an addendum that prior to this visit, I spent, an hour and a half reviewing the records, 100 pages of, blah, 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 whatever I have to document, and put that as a prolonged service or something like that?
Yes, absolutely. I would probably use the term in association or associated with this visit. My time to review previous medical records or other medical records was an hour and a half or whatever it was, and then have that documentation.
Because I don't think I've never used any of these codes for this, and again, as we said before, we're a referral center, and I can't tell you the number of times for the immunology patients or all these other patients we see going through pages and pages and pages of records, trying to be prepared for these patients, or they come with a book of records and
right.
leave them for you to go through after they've left, and we have to spend all that time going through, but we've never billed for those.
Absolutely, you should bill for them. Yeah, you may not get paid, but you should bill for them because you may get paid. So they're good codes to use. And there's one other code that is new for this year that I want to go over that the staff can use, and that's prolonged clinical services that is really done by the staff. And so if your staff is also doing some of this work for you and going through charts and pulling out information and seeing patients or working with patients or talking to the patients where you have them go in and do some of the work, then you can bill for their time when they're spending time face-to-face with the patient. So it's a new code. We haven't really seen how it's going to work yet, so we don't know how many times it's going to be paid and how many times it's going to be denied. But there are these two codes, the 99415 and 99415, which is the initial time that the patient would be seen by or be by the staff in addition to the E&M visit. So again, it's an add-on code. You have to have an E&M visit first, but then if the staff spends more time with the patient after you're finished, then you can bill for their time basically. And you can see an example here where the primary service defines the time when the prolonged clinical staff time begins, but for a 99214 level 4 follow-up visit would be 25 minutes, and time after that would then be accumulated by the staff doing face-to-face time with the patient. Okay, and as I said, we're not sure exactly everywhere, but I can see this fitting in with some patient education codes and some time that we spend having our staff go in and work with the patient in terms of learning how to use nebulizers or learning how to use equipment and understanding their disease better. So
Jerry, by clinical staff, are you meaning nurses?
Exactly, yes. So not non-physician providers, or non-physician staff. So it's not, physician comes under work RVUs, non-physician like nurses and MAs and other staff are not included in the work.
About social work.
Social work, as long as they're doing something for you that you've asked them to do for that patient, and their time is being billed or being paid for, then you can bill for it or you can use the code. Now, there's a little bit of a problem because it depends on how they're being paid. So if they're being paid by the hospital anyway, and that has nothing to do with how much time you spend with the patient, then you may not get RVU credit for that. But
Okay.
at least you've documented it, and you may get more reimbursement for that. Okay.
So could you give an example? Because it says, I'm trying to figure this out for a follow-up visit. So they come in, you spend 25 minutes for a follow-up, and then the nurse has to, what's the minimum time the nurse or social worker would have to spend to be able to use the code?
Well, it's the lowest level of code is an hour, so they'd have to spend at least 30 minutes on top of that. And I can't remember, you said the initial visit. So if it was 25 minutes, they'd have to spend, it'd be 55 minutes before they could bill the code. Because the 25 minutes would be the level 4, and then another 30 minutes would bring it up to 55 minutes.
Okay.
So it's, and I'm not sure that we're going to be using it a lot, but I think there probably are going to be situations where it could be used. So I think it's something that, again, this is the first year we've had it, so I'm not sure of all the places where we are going to use it. But having said all that, I have to move to the next part of the talk, which has to do with concerns that we have with billing, and that the concerns always come from the OIG report. And so every year the OIG puts out their work plan for 2016, and one of the components, the new components, I listed 3 here, one of the new components for their work plan for the OIG is to look at prolonged services and the reasonableness of the service. So I think that they've recognized, that is, the OIG has recognized that these codes can actually bring in more money to a practice, and so now they're wanting to make sure that there is sufficient documentation, and that's why I was mentioning that you have to document when you use a prolonged service code what required the prolonged service. I think you should still use them, but you have to document them and show that it was medically reasonable. I don't think many allergists are doing home visits, but the OIG is looking at home visits by physicians. The other thing is that they're looking at referring and ordering Medicare services and supplies, so that you all need to make sure that you have a Medicare provider number. And you can get that relatively easily online now, and everybody should have a number so that when they order something for a Medicare patient, that number is part of the record and that goes into the chart. Otherwise, the patient, Medicare won't pay for it. So we all need that number. One of the things that OIG had in their plan last year and didn't have this year, but I'm not sure it's gone, is place of service. And so this pertains to where the service was actually provided. And the reason that's important is because, as I just said, if a service is provided in a hospital, part of the overhead may be paid to the hospital. And if it's provided in a physician office, then the overhead is part of that physician office. So again, in the CPT book, you have all these place of service. And for somebody doing an office visit in an office, then the place of service is level 11 or service code 11. But if the place of service is in a hospital, then there is a different code. I think it's 22, I don't remember. But there's a different code that's used, and that shows you that hospital is already collecting their overhead, so they pay differently. It's a facility versus non-facility fee, and that's why it's important to Medicare, because they don't want to pay you a non-facility fee if you're actually doing the service in a facility. Okay, let's go back to the CPT book and look specifically at allergy for a little bit, and then we'll go on to ICD-10. This is all from the CPT book 2016, so I'm just going to point out a few things. You can go and look at it. Immunotherapy, parenteral indicates the codes do not apply to SLIT, so you have to, in the definition of immunotherapy, it includes the word parenteral. And you have to document a correlation of diagnostic procedures, clinical judgments, and so forth. So you can't have a diagnosis without having something in the record to say why you thought that patient needed immunotherapy. You have to have some documentation of the appropriateness of the procedures. And then finally, when you do skin testing, there actually is work involved in that. So there are work RVUs that go to the doctor, and that work is the test interpretation and report. So part of doing skin testing actually includes looking at the skin test results, making an interpretation of those results, and then writing a report, just like a radiologist would look at a chest x-ray and evaluate what they saw and then write a report on that chest x-ray. We are required to do that with our skin test results, and that is what pays us the amount of money that we get every time we do skin testing. Allergy test, the next page in the CPT book, one of the tests is 95012, which is a FeNO, expired gas determination for nitric oxide. And so the code is in the book, but I want to point out that just because there is a code for a procedure doesn't necessarily mean that all insurance companies will pay for that procedure. And they all have their own little ways of deciding whether they will pay for a procedure or not pay for a procedure. But you should always bill for the procedure, because the likelihood is if you don't bill, you won't get paid. If you do bill, you may get paid. So always bill whether you, if you're uncertain about it. Just to point out, 95017 and 95018 include both percutaneous and intercutaneous tests. So when you do testing for drugs or for venoms, you add up all the tests that you do, and that's the number of units for that particular code. So if you did 2 scratch tests or puncture tests and 3 intradermals, then that would be 5 tests for 95017 or 95018. And it's the sum total of all of those tests that you do that determines the number of units. And many of these codes have units associated with them, and so it's important to kind of understand that concept, and they'll always tell you what those units are. And so here it says specify number of tests, and then that number of tests will go in the units box on the billing sheet. So I guess the billing people at the various institutions will pick that up. Jay was just telling us earlier that he was down doing a peanut challenge, and so that's an ingestion challenge test. And I want to point out a couple of things to you. One is that in this situation, it's sequential and incremental. So if you're doing an ingestion challenge test, it has to be sequential and incremental. A place where this may come into play is if you're doing penicillin testing, you do skin testing, you decide you want to do an ingestion challenge to really meet the criteria. it really needs to be 2 doses, sequential doses of penicillin that are given. And again, remember this is a time test, so that the 95076 is the initial 120 minutes of testing. So think about how many minutes you need to code for that test. Remember, it's half of the time of the lower amount. So for a 120-minute test, you'd require 61 minutes before you could bill for that test. So it not only is sequential and incremental, but because of the time of the testing, it would require at least 60 minutes to bill for the 95076. And then allergy immunotherapy, we were recently talking to one of the major insurance companies, and they were telling us about some errors that people were making on coding, one of which was we have these codes that are in the CPT book, and this is 95115. That's when you give an injection of allergy immunotherapy, and it says single injection. And then 95117 says 2 or more injections. So if you give 3, 4, 5, 6 injections, it's still just 1 unit of 95117 because it's 2 or more. So it doesn't matter how many more. If it's more than 2, it's still just 1 unit of 95117. And they were telling us stories about people that use multiple units of 95117 and were trying to bill higher because of that. Some of the codes in the CPT are rarely used. This is a combination code. We're not going to go over it because it is infrequently used. But there are some other codes that we do often use, and one is 95165. This is for extract. And if you read the definition, it says professional services for the supervision and preparation and provision of antigens for allergen immunotherapy, single or multiple allergens. And you specify the number of doses. So it doesn't matter how many antigens are in the vial. So there can be 5 or 15 antigens in the vial, and it still depends on the number of doses that you anticipate that you will give from that vial that determines the number of units that you will bill for. And you find that by looking at this. You can see they refer to the CPT assistant in February of 05, and when you look at that CPT assistant, it says the prospectively planned to be administered number of injections. So the doses, if you were starting somebody on immunotherapy and you had 3 vials, and out of the first vial you expected to get 6 doses, then you would bill 6 units from that, even though there might be 10 doses in that vial. So you would bill the number of units that you expected to get from that vial, regardless of the amount in the vial. It's a little bit different from Medicare, and we can go over that if we have a chance. But I just want to point that out to you that if you have a shot sheet that says, well, out of the first vial I give 6 shots, and out of the second vial I give 8 shots, and out of the third vial I give 10 shots, then the insurance company can come back and look at that and say, well, this is what you expected to give, so this is what I'm paying you for, not 10 from each vial. And then venom immunotherapy is a little bit different from other immunotherapy, and here it depends on the number of venoms that you give at a single time. So if you expect to give 3 venoms, even though they might be mixed Vespid, and it's just 1 injection, that's still 3 venoms, so the code will be 95147. And similarly, if you give 5 venoms, even though it's mixed Vespid and honeybee and something else, then it'd be 95149. So it's the total number of venoms that you're giving, not the number of injections. Okay. I just want to quickly cover this because it has to do with some of the biologics that we give. 96372 is for therapeutic, prophylactic, or diagnostic injections, sub-Q or intramuscularly, and that's for most of our injections, like if you give epi, but it may also be for some of the biologics if they're not highly complicated, and some of the insurance companies will not let you use this chemotherapy code 96401. They require you to use the 96372. So our advice is that if you're giving biologics and if you're doing a lot of that, that you actually talk to the insurance company first and ask them what they want you to use and use what they want to bill appropriately. Pulmonary functions, I just want to briefly mention that when you read the book, when you look at the book, you can see that for instance, 94060, which is these pulmonary function tests before after bronchodilators, does not include the medication that you give with it, so you can report the bronchodilator supply separately if you are using a bronchodilator, albuterol or something, when you're doing the reversibility test. And similarly, 95070, which is a series of spirometries, you can report the antigen separately when you bill that code. So it includes all of the maneuvers, but it doesn't include the antigen or the bronchodilator in the first code. Another underused code I think that's important to think about is the 94664, where if you have a patient and you're trying to explain to them how to use their metered dose inhaler, and we know this is important because patients so frequently use them wrong, you can bill for that. You can only bill one time per day of service, but you can bill for that along with your E&M visit. So it's a separate code, 94664, and it's for the time you spend teaching a patient how to use their metered dose inhaler correctly. So often you'll get claims denied. I'm going to go through this very quickly because we don't have a lot of time left. And one of the reasons that the claims can be denied is because of what are called the National Correct Coding Initiative. And this is a series of codes that come out frequently, and these codes are in 2 columns, and they're on the internet. You can just Google NCCI, and you can download this file. And one of what they show you in this file are the codes of note and the date that the edit became active, that is, that you could not bill those 2 codes at the same time, the date that the code was deleted if it was, and also whether you can use a modifier to break the code. So if it says 0 in this column, like down here, you cannot break the code. You just never can use those 2 codes together. If there's 1, then it means a modifier is allowed, and most of the codes will have a 1. And then if it's a 9, it means it's not applicable. So for allergy, some of the codes that might be important would be spirometry, 94010, and a console code, 99241. And you can see here that in 2014, it became active. In 2014, it became inactive because they made a mistake, and we complained about it, and they said, well, it's no longer applicable. But many of these codes, like the spirometry with a follow-up visit, have this 1 here, so it means that you can use a modifier and you can get paid for it if you use the modifier. And the 2 modifiers that we can use to break the code are 25 and 59. So those are the ones that you use. 25 is when you use an E&M in a procedure. 59 is when there are 2 procedures done. I think I just have a few minutes left, so I'm going to run through this very quickly. ICD-10. Okay, you need to know anatomy because part of ICD-10 requires laterality, and so we can't just say they have acute serous otitis. We have to say whether it's in the right ear or the left ear. And you're going to hear a lot about sinusitis in a minute. They talk about specific sinuses with ICD-10 coding, so you need to, as best you can, define where the disease is. Severity of asthma has come into play, so we have mild asthma, we have moderate persistent, mild persistent, and severe persistent asthma, and then we also have whether it is uncomplicated with acute exacerbation or status. So we look at severity and also whether there is an exacerbation of asthma in ICD-10. I'll just talk briefly about this. So there in ICD-10, and I showed you the book a little bit a couple of slides ago, but what I did is I just went to the internet and I downloaded the PDF files for ICD-10, both for the tabular version and the index version of ICD-10. And I like them, and this is actually from that. I like them because you can go in there and use the find function and go to specific codes, or you can go to specific diseases and very quickly go through ICD-10 and find out what you need. So in some of the codes you can look at, well, they'll have in the book or on the internet, as I said, things like acute nasopharyngitis, the common cold, and it says it excludes one. So if it says excludes one, it means you cannot code this code, J00, with any of these other codes, sore throat, rhinitis, pharyngitis, and so forth. So you just can't code the two together. On the other hand, if it says excludes two, it means you can code them together, because you can see the logic here. Somebody might have a common cold and also have a diagnosis of allergic rhinitis. So the excludes one and excludes two is a new concept in ICD-10 that we didn't used to have. The other new concept is this 7th character code, and there are a number of codes that we're going to use a lot in allergy. This is toxic effective contact with venom, and the codes are called A, initial encounter, D, subsequent encounter, or S, sequela, but they really don't mean that. What A means is any person receiving active treatment. So it can be the first or the second time the patient is seen. It can be multiple doctors, but as long as it's active treatment for a disease, you use the 7th character A. If a patient has been treated, say they went to the emergency room, they were treated for their anaphylaxis, and you're following up in your office, and you're still using the diagnosis of anaphylaxis, that might be a subsequent encounter where they're receiving routine care for their condition. So that might be a D. And I'll show you an S in just a second. So here's the 7th character in the placeholder. Here's a patient who has a deviated nasal septum because they were struck by a baseball and they had deviation of their nasal septum and fracture, which caused a fracture of the nasal bone. So there, the deviated septum would be the first code, J34.2. And then they had a fracture of their nasal bone, which caused the deviated septum. And then the reason for the fracture was they were hit in the face with a baseball. So there were sequela, and the final diagnosis was a deviated nasal septum. So you can see how that works, and I've given you a couple of other codes in here that are new for ICD-10. We often see patients who underdose on their medication. They don't take their medicine as it's been prescribed, and one of the reasons they may not take it is because they couldn't afford it. It was financial hardship, and these codes are going to be more important to us when we're actually evaluated for the care of our patients. If a patient with asthma is not doing well because they have an exacerbation, but it's not our fault, we prescribe the right medicine, but they couldn't afford it, then we can document that in their chart. And so I've given you a couple of how would you codes, and you can read those over and do them at your leisure. We'll stop there because I think I'm running into chronic sinusitis.